Today, our guest is Professor Lukas Rasulic, who is a globally renowned neurosurgeon, full professor of the Faculty of Medicine, University of Belgrade, and head of the Department of Peripheral Neurosurgery, Functional Neurosurgery, and Pain Management Surgery at the University Clinical Center of Serbia. He has made significant contributions to peripheral neurosurgery and holds leadership roles in numerous prestigious neurosurgical societies. Dr. Rasulic's work continues to inspire advancements in neurosurgery worldwide. Before we begin, I want to take a moment to acknowledge the invaluable contributions of several European neurosurgeons who have been instrumental in advancing the field of peripheral neurosurgery and the ENS section of peripheral nerve neurosurgery. Professor Lukas Rasulic has shared his long-standing collaborations with Dr. Christian Heinen, Dr. Thomas Kretschmer, Dr. Gregor Antoniadis, Dr. Stefano Ferraresi, Professor Shaman Dockhand, Dr. Martin Males, and Dr. Willem Pondak. Their expertise and dedication have been pivotal in shaping this specialized area of neurosurgery. Professor Lukas Rasulic, welcome to Neurosurgery Tales. It's a true honor for me to have you here today and to discuss peripheral nerve surgery, neurosurgery in Serbia, and so much more. Welcome.
Thank you. It's my pleasure to be here.
I will start right away with a big question. What has been the biggest challenge in your career, whether in surgery or leadership or maybe research, and how did you get through it?
Biggest challenge in my career was to clarify which direction I would go in terms of my future expertise in the field. And that was, fortunately for me, in the very beginning of my career. And at that time, 30 years ago, more than 30 years ago, general neurosurgery was very attractive. It was the time of the open vascular surgery, open surgery with neurology. In spine surgery, it was completely different time comparing to nowadays. There was no minimal invasive approach and procedures at that time. There was a lot of challenges in not only educational program, but generally speaking in performing the surgeries. When at the time I was the beginner and I was starting. I was first clinical attendee, then I was on my residency program, and very quickly, practically immediately during my clinical attendee program, I was very lucky to realize what will be my future field of expertise in terms of doing peripheral neurosurgery. Because at that time, there was an era of heroic neurosurgery, especially in this part of the world, when you perform surgery with many hours and do best of your surgical practice in the particular case due to the many different reasons. We can talk about this later. Many different reasons. Patient, unfortunately, either passed away, either some great morbidity. And at that time, it was not clear for me to see what kind of surgical procedure will really help the patient in terms of providing him something which would be not only life-saving surgery, but reconstructive surgery. And apparently, it was very clear to me, and I said I was very lucky at the time that I had a great mentor. He is still a mentor. He was at that time the best neurosurgeon in this area. His name is Professor Miroslav Samaric. And he was the only one who performed the peripheral neurosurgery, especially brachial plexus, not only in former Yugoslavia, but in the region. Also very involved in research and scientific processes. So his publication at that time was also still nowadays very famous. So I joined him. He accepted me. During our regular activities, everyday activities, he just gave me an opportunity to work on brachial plexus. So my master degree and my PhD thesis were from brachial plexus surgery. My master thesis was intraneural topography and surgical anatomy of the and systematization of the brachial plexus and its importance for the surgical procedures and reconstructive surgery. So my PhD, consequently, after this 4 years or 5 years after my master's thesis, was about reconstructive surgery of the brachial plexus, and until nowadays, that 2 PhDs are to this scientific work were the only one. They are practically still the only one in this region in academic manner, which are completely solely devoted to the brachial plexus and peripheral surgery. Coming into the field and coming back to the question, this challenge was very early solved, practically by itself, automatically, because I was at the time that we were in the war period in former Yugoslavia. We have a lot of surgery, time, all type of surgery. There were a lot of cases of gunshot and missile injuries of the peripheral and brachial plexus. So I get my surgical experience very early in the field, and then step by step I start to realize that at least with the peripheral surgery you cannot harm your patient if you are well trained, know what you are doing, and understand the problem with your surgical skills, which you are learning and improving lifetime. You can really help your patient in terms of restoration of the function and improve his quality of life. And you will not be in the situation to operate the patient and do brilliant surgical procedure, remove extensive tumor or clip basilar tip aneurysm through the third ventricle or any other surgical approaches, and do brilliant surgery, and the patient later on, due to the natural history and the complications and a lot of other problems, either passed away, has a significant morbidity in terms of quality of life. Of course, I performed many of these surgeries that I'm performing some of them nowadays in a modern way, in a modern fashion, in the terms of neurosurgery of the 21st century, much vascular, but some 50 to 70 cases per year. There are some oncological cases in terms of oncology, and 9 cases in terms of degenerative spine disease or tumors or something like that. I'm not dealing now with other problems in neurosurgery because there are other specialistic departments for pediatric neurosurgery in our center. Trauma, or endovascular, neurology, or in spine. But during all this time, I perform many of these surgeries, and practically now I'm the head of the department of peripheral neurosurgery, which is the department of peripheral neurosurgery, functional neurosurgery, and pain management surgery within the neurosurgical clinic. So this is a really unique situation because we have 26 beds only for cases for peripheral nerve functional and management. Except the other patients who are not from this pathology in this department, if I accept this or some of my assistants accept it. And finally, I went through many of, let's say, difficult situation in handling different type of pathology through my career, and experienced a lot of problems and situations, either with the patients, either with the families, either with the while I'll practically step by step come to the position to do only peripheral nerve surgery. So we develop our neurosurgical clinic nowadays that I am not obliged to do any kind of these other procedures beyond the peripheral nerves, except if I want. If I want, I then accept the patient, and after thorough preoperative evaluation. I operate the patient in the best possible way, and that works. That is working so far so good. It will not touch it. On the other hand, all patients, all type of pathology, all type of problems in surgical problems in peripheral nerve system, where all type of disorders who need surgical treatment or potentially might be surgically treated, whoever them are coming in my department for from practically all Southeast Europe.
I see.
I said I have several patients from Moldova also, especially from and from Romania, from Albania, North Macedonia, all countries from former Yugoslavia, etc., etc. So that was the biggest challenge in my understanding of the philosophy of neurosurgery in terms of okay, fine, even the patient is let's say, treated well and he went well, for example, with a glioblastoma, you didn't cure your patient. You help him, you prolong his survival rate, and you do everything for him in terms of helping him to fight with his disease in the best possible way, in a modern fashion, in a combined neurological approach, according to all current standards in neurosurgery and neurology. But you didn't cure your patient. And in this field of peripheral surgery, you cure your patient. Of course, there is a possibility for there are biological challenges in the field of peripheral surgery that perform excellent surgery, but several factors can make a significant impact on the final outcome in terms of achieving useful functional recovery in the patients. So this is something which you have to very clearly emphasize to the patient and discuss within thoroughly. But if you perform, let's say, surgery according to the standard operative procedures and protocols in terms of reconstructive brachial plexus and peripheral nerve surgery, you can accept good results. Of course, these results are not evident immediately. For this, time is needed because of the time span in terms of the process of the regeneration of the axons, between the gap of neural tissue in peripheral nerves to obtain possibility to overgrow the axons from proximal to distal nerve stump and find the muscles, target muscles and effectors in a best possible manner. In younger patients, results are excellent. Even in older patients, you can expect good results in terms of having the good results in terms of you help your patient to restore his function, and for somebody who has nothing, I mean, he lost his function of the hand or the upper limb or the lower limb, and for somebody who has nothing, a little is lost. There is also another level of the game in terms of patient outcome and patient satisfaction and improvement of the quality of life in this grading system after surgery and peripheral lesions. This is something which at least you are not, let's say, you are patient to think about could I do something more to treat my patient because he has playing with a significant morbidity or passed away or something like that. So now here you know that you can expect good results in terms of everything. All but factors who can which can have a significant impact to the final outcome are fulfilled. Just you need a time, which is approximately 12 to 14 months after surgery. Consistency in physical therapy and multidisciplinary approach in treatment of this patient is mandatory. So patient understanding that he must be very consistent in his efforts in physical therapy following surgery. So day by day, year by year, I have a very big series of patients operated with a significant outcome and evaluation in terms of 2-year follow-up, because 2 years is, let's say, time span that you can finally evaluate your results in terms of achieving this partial goal. So this was my biggest challenge in my career in terms of I would say generally. Particularly, there were several cases which are not in peripheral neurosurgery. Even in peripheral neurosurgery, you have a point of no return when you have to decide something that after after that you cannot do anything more for your patient. The decision making process made a wrong decision. This is a end of the story. But if you made a right decision, your patient can expect a good functional outcome. So even in the peripheral neurosurgery, there are some of the situation, not so many like in other fields. But in peripheral neurosurgery, you have a clear situation in terms of that. And I think that we should not speak now on some of the individual cases which were challenging in terms of under-recognizing, underdoing, overdoing, or whatever in terms of something which is part of everyday practice of each individual neurosurgeon worldwide.
And you obviously, peripheral neurosurgery is so specialized, and you're an expert that are seeing, as you mentioned, different patients from a big part of Eastern Europe. And how do you keep your energy and avoid burnout after so many years in this field?
You mean my personal energy?
Yes.
Well, this is a question that everybody asks me in terms of this everyday practice, but the answer of this is very simple. Find exciting and worth doing all these things in terms of helping people. Generally speaking, and then particularly with my surgical work and surgical skills to help the people in terms of to restore the function. So this is the biggest satisfaction and also biggest motivational factor. And beyond that, that is my personal characteristic is my high spirit. I would say tuned on that level. How to say it? You understand? My personal Holy Spirit or whatever, which is driving me to do what I'm doing, is beyond on this highest level. So for me, everything is possible. There is no mission impossible. Always make a game changing a situation, turning mission impossible into mission possible. And this is something which is for me very exciting. Still nowadays, I'm 60. Will be now 3 months. We'll have months of my 60th birthday. So still, I'm very excited and enthusiastic when I'm doing something, either with the patient and or with some idea which is not dedicated to my own person or my own interest, but devoted to higher goals to everybody, and can have some significant impact on improving the community. So this is something which I'm doing every day. I used to do it so far. I'm doing nowadays, and I will do it all the time as well, because this is something which I'm not thinking about, am I tired or I'm not tired, or should I do it or should I not do it in terms of any kind of calculation. I'm of course evaluating the importance of this, what this is doing. But if I have a clear vision and clear picture about that this is a higher goal, which will be useful for wider community, for everybody, for me, it's out of any kind of discussion, or should I do it or not? And I'm doing this without thinking about time or any other, let's say, potential reasons why people can say, okay, I'm not interested in doing this because of this or that. So that is some. I hope that I somehow explain this kind of driving force, which is driving me in terms of answering on your question.
Yes, and with everything that you've done, have you ever wondered if the demands of this career are too much, even with a high driving force?
I never think like that. You understand it? So I'm not in terms of making a cumulative effort, no effort in terms of putting things in my CV, just to have this extended CV in any manner. I'm just doing things, you understand me? I'm just doing in terms of what I think that important and have significance, as I explained a little bit before, doing things, and then try to fulfill all criteria, all goals, all standards to achieve the success, and that's it.
And have you ever done your best in a surgery and still feel it was not enough? How
Yeah,
did you deal with that?
my best surgery, and the still it was not enough.
Yes. Maybe early in your career. Yes.
So even nowadays, it happens. Even nowadays, in peripheral surgery also, especially in the most difficult cases, such as erosion of the roots of the brachial plexus in all five roots, in one lesion, a one plexus lesion, you are always thinking that you might do something more for the patient to help him to, although this was and this is very well known, the strategies for treatment of these patients are also very well defined. But you have to choose individual strategy for each individual patient according to the his characteristics. And yes, some patients have some, I used to have some feelings that might be that for the patient could be done something more in terms of doing this. But this is what I also mentioned, point of no return. You understand me? When you come to this, you have to think and make decisions uh, accordingly, I mean, on time, in terms of preoperative planning and as well intraoperative process, because most of our decision-making process are final decision-making process is ongoing during the intraoperative exploration or the brachial plexus or peripheral nerve. So then you make a correlation between not everything, clinical findings, image findings, neurophysiological findings, intraoperative findings, intraoperative neuromonitoring findings, and then you have final decision-making process and make final decision within the surgery. In 92% of cases, approximately, know preoperatively that you can what you will do for the patient and what is the best possible treatment option for the patient. 9% of cases, generally speaking, following this, what I just mentioned, you have to decide intraoperatively. And there are no double-blind, randomized, class 1 evidence-based studies in peripheral surgery for saying this is something to be done in this situation. This is very complex and very individually based and must be individual to the patient. We are always, this is a famous sentence of distinguished surgeon, peripheral neurosurgeon, Professor Robert Skinner from Mayo Clinic, is always saying we are still in the situation to make a point-based decision in interoperative decision-making process is in this kind of situation. So this is based on experience and the knowledge of the surgeon. Coming back to your question, yes, there are still some patients in which I have some considerations following surgery, like famous Flash song, should I stay or should I go? Should I do more or should I not do more? This is something which was Hamlet's question to in some manner in these circumstances. But this is surgery, and at the end, this will not harm and minimize the planned outcome for the patient, expected outcome for the patient. But in terms of thinking that it might be even better, yes, there are some patients, there are some situations, not so many, thank God, but there are not so many. But nowadays, there are not so many in terms of my experience and my career. Also, my team is very well trained and very well equipped. Very specialized team in peripheral nerve surgery, highly trained in the best possible manner, which was all standards in peripheral nerve surgery. And they are capable to do practically 90% of all cases, 95% of all cases. So my department is very well defined. Also nurses, also nurse practitioners, also physical therapy. So we are working as a completely devoted team for peripheral nerve surgery for many years. And there are some we call it standard operative procedures, like in special forces or in any other other units which are doing this kind of profession, that everybody knows what to do. You understand? We are something which was very well defined, and I did my best, and I'm doing my best till now as head of the department to implement all this in everyday practice. Even I'm not in my department, my team knows everything what is necessary to be done. Of course, they can always consult me, but generally speaking, we have a very good results in let's say when we have a yearly evaluation. At the end of the year, we always have a what this yearly debriefing in terms of analyzing the data. But we have every day a briefing, morning briefing and afternoon debriefing about what we are doing in terms of everyday practice, everyday activities, either in the OR, either in outpatient clinic, either in educational manner, because my team is also involved in academic practice. Two of my assistants are assistant professors of neurosurgery. I'm full professor. They are assistant professors, and two of them are neurosurgeons, which are not still included in academic career, but they will be, because we are a university neurosurgical clinic. We have this part as every day of our activities. And of course, I have many residents from Serbia and this region, but I have an international fellowship program for education in peripheral neurosurgery, which is highly evaluated within the international neurosurgery community. Nowadays, I have two colleagues, one from Tunisia and another one from India. And from 2018 on, except in COVID time, until nowadays, there were 48 of them spending from 1 month of observership, 3 to 6 months, some kind of fellowship, and then 6 to 12 months full fellowship. And beyond 12 months, I have one from Mexico who made a PhD here in Belgrade in my department for his peripheral nerve thesis. So this is something which is fully devoted department in this field of peripheral nerve surgery. So this is something which nowadays we are not in the situation to allow ourselves to think, should we do something more for some patient? You understand? And this is not, by the way, this is not professional on the, let's say, highest professional standard what we are trying to implement every day. So theoretically and practically, there were some cases, but nowadays it's completely minimized, or practically there is no situation like that.
And you obviously are a leader, not only leading this clinic like residency program observership, but also you done so much to improve neurosurgery worldwide. And what's the most important lesson you've learned as a leader?
Listen. By the way, this is also my personal characteristic, but listen, and then when you listen, and when you establish a communication on the ground level with your colleagues, or your younger colleagues, or other staff, or anybody who is under your leadership, you have to listen. Then, in terms of what they are, what to say, what are they need, what they suggest as their observation, and we integrate everything of this observation and communication in everyday practice in your attitude and your ability to then implement what is your leadership idea, and something what is you think that it is important to be implemented as a leader for everybody. Again, I'm coming back. This is a leader is not for itself. A leader is for others. Leader is somebody who serves to the community, each individual person, to everybody who is under his leadership, and in community which is integrated in the field, what you are doing, what you are doing, what you are working. Right? Yes, this is something which is most important, and of course there are other important things such as you should not, as a leader, deal too much with the theory, trying to explain everything on the theoretical level, because this will not give up result. I mean, full results what you want or you wish as a leader. Practicing as a leader in terms of like in the Army General, leading the army in terms of commanding, follow me, or saying straightforward. You understand it? So if you are commanding that your army is going to fulfill their tasks, sitting somewhere and not being with your army, this should not be as much respected as you are leading your army together with them and say, follow me. Now we are going to do things together, and you will see then practical result. You will see why I'm telling you this. You will see why should we do this, etc., etc. And this is also time consuming and also energy consuming. And this is something which you can, this pathway, you can expect a lot of disappointments. Cancellations in terms of being a part of this, I would say, especially push, special task force in terms of doing the activities. And due to his disappointments, more than several colleagues who started wanted to become a part of my department and my team. They withdraw themselves from all these activities because they finally realized that although it looks everything that it can be done easily, peripheral surgery is not so demanding, like quoting surgery, etc., etc. There are myths, there are facts and myths about peripheral neurosurgery which we boosted already. Myself and my colleagues who are neurosurgeons doing peripheral neurosurgery worldwide, we devoted our careers in terms of boosting these myths about peripheral neurosurgery and improving the importance and awareness about peripheral neurosurgery within the neurosurgery. And during within all these institutions and organizations such as European Association, American Association, World Federation, and other activities, divisions and committees and sections for peripheral nerve surgery, which are very well established and very well doing their job. And then we have a task force list or to-do list in terms of either we should go on site and work with the colleagues and neurosurgeons everywhere in the world in terms of implementing peripheral neurosurgery from basic through advanced to the complex level in their departments, or doing this kind of online education and support to everybody, or organizing educational webinars, seminars, congresses, whatever, in terms of improving this knowledge about peripheral neurosurgery. And finally, accepting these younger colleagues from other countries in our department for a fellowship program. So this is something which is very well defined, and this is working very well since, as I said, a group of devoted people, for example, Mariano Sokolski from Argentina, Fernando Guedes from Brazil, they were also from now United Arab Emirates, a group of American United States neurosurgeons who are starting from the legendary, recently late Professor David Klein, and the other colleagues, Robert Spinner, Eric Zager, many other colleagues, Alan Hudson, other colleagues from the United States who are in everyday communication. You understand? We are doing things in terms of planning all this and working in terms of organizing everything, what I mentioned, within the proper planning for every huge neurosurgical event, such as WNS, CNS meetings in United European Congress, in here, Australian Asian Congress, World Congresses, etc., etc. So this is a long run. This is a long run. It was this is happening. I'm actually participating in all this in last 20 years in terms of international community together with them. So we have a motto: keep on rolling in terms of doing again and again and again everything what is necessary to be done in these circumstances to educate people in terms of requirement. And I would say that we have a significant results. We have results in terms of, because historically, although you can find in all neurosurgical classical textbooks particular chapters about peripheral neurosurgery, and this is a part of the residency program in every neurosurgical center or institution. Peripheral surgery was a little bit abandoned during the from neurosurgeons, and plastic surgeons, orthopedic surgeons start to overtake this field from neurosurgeons from the beginning of 2000. But we, I think, success to bring back peripheral neurosurgery in neurosurgeons. Maybe it can be done. I mean, maybe this level of these activities within the neurosurgeons can be increased. I agree. It can be increased by the other neurosurgeons. It depends also on different factors. We significantly get back all this peripheral surgery to neurosurgery. Although we have excellent communication and interactive activities through the multidisciplinary communication with the orthopedic surgeons and plastic surgeons and all specialties who are doing anything related to peripheral neurosurgery, because we realized that something which potentially in future can be sub specialization in terms of somebody who with all the nerve surgeon, you can say nurse, not orthopedic surgeon doing neurosurgery, or a neurosurgeon doing nerve surgery, or a microsurgeon doing nerve, all together to perform all this what is necessary for a patient to be in one man in terms of one specialization, such as so-called nerve surgery. We are still far away from that. But this is something we are also discussing about how we do. In the United States, I'm very satisfied and pleased that communication with the colleagues that I mentioned, then again with Alan Belsberg, with Winfrey, Ahmed Hanna, all other colleagues who are doing this very, very on the highest level in terms of working in their everyday practice, also organizing these academic activities, educational activities. I'm really satisfied and I'm very pleased and honored that I can collaborate with them and be part of this, because globally, because you have now new trend in neurosurgery, which is developing very fast and furious, which is so-called global neurosurgery. Neurosurgery is, let's say, new subspecialty in neurosurgery, which is integrated all other subspecialties in neurosurgery in terms of improving the neurosurgical standard care and service everywhere in the worldwide, especially in low and middle income countries. We are doing this thing together, and I'm very proud to be part of this team and very happy to be it, because I learned so much things from them, and we together achieve many very successful activities, events, and somehow this is peripheral surgery is now, in my opinion, well recognized within the neurosurgeons again, especially with the young neurosurgeons. And the interest for peripheral neurosurgery is coming back or increasing again.
Peripheral neurosurgery is extremely specialized. And what new idea or techniques in peripheral nerve surgery you are most excited about?
Artificial nerve, which is science fiction so far, but who knows? Creating something like this completely artificial nerve and implementing in the body of the patient in terms of avoiding any kind of immune response, and accepting this, and to be useful in terms of transferring the resident action. This is something which is on the let's say, a research level. It's very actual and very hard work is focused on that. On the other on one side, and on the other side, the research level, everything what can be used successfully for the augmentation of relevant generation and minimizing biological challenges who can, let's say, diminish successful regeneration of the axons is also part of the research level, including everything what is contemporary science and technology are giving in the field. So this is the other group of people who are doing this. We are also involved in this part of research because at the end we are the end users. You know, we are the one who should, like some situation, implement this to the patient, to the pet. So we have to be very well informed, not to mention that we have to know practically everything about this, in terms of following what is going in research level, improving the quality of this. I'm not sure that still, even I cannot, not on this moment, I cannot say that I believe that this will be possible in the future, near or later.
Do you think it's going to take 5-10 years?
But I cannot exclude this possibility, you understand? I cannot exclude this possibility. I said this is impossible because nowadays everything becomes possible following new technologies, artificial intelligence, sciences, resources. So this is
And we talk about minimal invasive surgeries in skull base, in like cranial surgeries. Is the same philosophy applied to peripheral nerve surgery? Like it doesn't matter the size of the incision, it's how you actually perform the surgery?
I would say these are surgical penitents because in all times, in all situations, from beginning of my career and up nowadays, there is always the same story about small incision, a small surgeon, big incision, big surgeon, or small incision, big surgeon, etc., etc. This is something which is completely related to any kind of this, in my opinion, any kind of this practical treatments, except that your incision is your incision. You understand? You are a surgeon and you're doing incision. Your incision is incision. So you are doing incision either small, it's enough for you to go through this incision and to the minimal invasive procedure to do this, or you have to extend your incision. To plan a bigger incision because of the depend on the pathological process or surgical target what you are going to operate. Nowadays you have a minimal invasive procedures with endoscopic and robotic surgery that you from 2 or 3 holes for removing from the, for example, lumbosacral plexus or other big tumor from pelvis or etc. Especially general surgery. In neurosurgery, endoscopic and robotic surgery is also in process of developing very fast and furious. And also, this is I'm more sure than for the artificial nerve that this kind of technology, which will be useful for the patient, also for the surgeon, can also be in everyday practice. Depend, of course, on the level of the surgical service. Generally speaking, surgeon is incident, and no matter about the size of the decision, the results are behind the decision. You understand?
Yeah. So the idea and philosophy, the principles, is the same as in the surgical surgery. It doesn't matter the incision. Yeah, it's how you actually.
Well, okay, the size of the incision has some kind of importance, but it is not predominant for final outcome or whatever you intend. So you can rely on your surgical activities and everything on the size of the incision. This is not let's say information.
And as a leader of Serbia neurosurgery, what's your vision for the future of neurosurgery in Serbia? What do you think is going to happen?
In general?
Yes. Yeah. how you see it doesn't matter in general or peripheral nerve surgery.
Well, you cannot split this because everything what is going on globally is going on locally. You understand? So think local. This is also my philosophy. You have to be ready to implement everything what is globally developed and here to be successful and useful. You should try to find a way to implement locally in your local environment. In terms of what will happen in future, nowadays you have a brain-machine interface. You have practically robots who are doing independently many things. You have robots who are controlled by many things. And so in the future, in all parts of life, you will have a situation that, like in Star Wars, may the Force be with us. Maybe we will face with artificial intelligence and technology in terms of they are another creatures who are able to do whatever is necessary to be done, starting from the big things, not only in surgery but generally in life. Then in surgery or in neurosurgery or peripheral surgery. So this is something which in the future can be expected, and this leads to the minimization of the need for the humans in general. You understand? So in terms of doing something, this is already happening in all industries or in other fields of not only medicine but in general. So automatization and robotics is in the future a real challenge. If you want to, let's say, know something more about this, I can recommend one interesting book, which is so-called Earth 5.0, which is written by the investigator Karl-Heinz Land. I know him personally. He was my guest in Belgrade here for when we discussed all these things. We did a great presentation about this. But this book was published first edition in 2019. So far, received several more editions, and now can be say Earth 10.0. You understand me? Because he is prediction in terms of what will happen in the near future is very, let's say, controversial. I mean, of maybe somebody will like it, somebody will not, but this is something which will happen in the future or later.
Lastly, what's the hardest decision you've ever had to make in surgery? And if you had to do it again, would you do it the same?
Hardest decision this is also related to the each individual phase of my career, you said. So at that moment, why it was this kind of thought of mine experience now, from now, for example, 10 years ago or 20 years ago, my decision process should be completely different in terms of this. At that moment, something which was, seems to me that it was the hardest decision anyway. We are talking about surgery. So generally, there were there were several hard decisions, but which now, when I'm looking from this position now, from this time, this decision were already predefined. You understand? Things must happen like that because this is not just a simple, let's say, washing of my conscience or cleaning something in terms of verification, something which is already there. But somehow, neurosurgery is now in the situation that from the biological point of view to the pathological up to the surgical and finally to the philosophical level of understanding and integration in terms of decision making process. Neurosurgery itself and science and technology already, especially in having in mind these biological aspects, nowadays you have a clear situations. You are not in the situation that you have to make this hard decision in this circumstance. If you have to say, for example, in the field of peripheral neurosurgery, decision for the patient is there's a malignant peripheral nerve sheath tumor, which is progressively, rapidly developing. You operate the patient, remove the tumor radically, but a few months after that, patient is have a recurrence. Then you operate patient again. Then you involve all kind of neurological treatment, etc., etc. Then finally, somebody say the only possibility for the patient is to amputate his leg. I didn't make decision for any amputation so far, and I always strive to do everything what is necessary in terms to be done, either from surgical point of view, either from oncological point of view, to keep the integrity of the. In some situation, you, for example, even cannot perform amputation of the extremity because of the situation that we have extremely high lesions, which are practically at the level of the spinal cord and the roots, etc. So you cannot amputate the limb and save the life of the patient in this circumstance. And this is also some decisions which are difficult to be decided, but somehow through the time, through the development of neurosurgery and everything what is related to science and technology, this kind of decisions are not so frequent. You understand? You don't have, because everything is clear, everything is very well defined. So you have arguments pro and the contra for every kind of decision process. You know how it say you have to make decision even if they're wrong.
Yeah.
So this is something which is also in that manner you will learn to make proper decisions and the right decisions. And of course, you could not have too many wrong decisions to learn to make to make the proper decisions. But this is also part of the process and the progress. So I cannot recall any kind of situation that is that kind difficult because I'm not in a situation that I have patients who have to be, let's say, removed from the ventilators to remove other things with their life support, etc., etc., also the brain deaths, etc. Many others. I'm not very frequently in this situation. I used to be in a previous period, but generally, you understand me. This situation is very difficult when you have especially when you have empathy, when you have a situation, when you have a young patient, when you have a lot of this kind of at that moment, if you think that these are the decisions are hardest in my life or the most difficult in my life, but this was the decision which was, in my opinion, totally predefined, and in the future will be another one which will be looking like harder than the previous one, and so on, so on. So decisions are difficult. This is how it is. You understand? You have to make decisions. This is what our surgeons are doing.
Professor Rasulic, thank you so much. It was a very inspiring interview, and I'm so glad that I had the opportunity to discuss peripheral neurosurgery with you specifically, because this is the first time we discussed peripheral neurosurgery on the podcast. So it was really interesting, and thank you so much.
Thank you once again for the opportunity. It's my real pleasure and privilege and honor to have this kind of conversation. I hope this will be useful for the audience.